Okay. Unexpected post-op LASIK complication, the lesson learned is my topic. These are my financial interests. When you look at LASIK complications, in today's context, we're looking at glare, halos, blurring of vision, asthenopic symptoms. I would like to divide my talk from optics, pathological alteration post-surgery, ocular motility, the personality, and all that goes into making a patient unhappy, which includes all of them. The approach to unhappy patient is a very detailed examination, which I don't want to dwell into, but it's all about from your tears to brain, try to look at everything possible which can make him unhappy. The visual assessment, the dry eye assessment, but it's important when you look at dry eye to look at the tear film very closely. There are different types of tear film assessment today, which looks at an optical scatter index. But if you don't have it, if you are having a good tear film quality on your Shermer's or T-Bud, that itself would be a very good way to assess the quality of the tear film. But if you have access to it, today there are a lot of new technologies where based on the tear film itself, it will tell you the depth of focus, the vision changes as it increases with your T-Bud parameters. A good T-Bud, a good vision keeps your tear film perfect. When your T-Bud is fluctuating, you can see that there's a lot of variation out there. This is a classic example of what I just showed, a perfect one and imperfect tear film. And the scatter is related to these kind of tear film, which increases your glare. So glare just shows, this slide just shows the glare can just come directly from your tear film itself. This is not part of the seminar today, but dry eye treatment is very important. You can look at the medical line or you can look at the surgical line of treatment. When you look at the pathological alterations of it, it's most important to rule out topography, ocular aberrations, to rule out a decentration or central small zone or undercorrection or overcorrection. This is an example of a good centration and a completely decentered ablation. And you can see the quality of vision here. We introduced this concept of field nomogram to evaluate decentration. Decentration is when, when it's decentered by more than 5.5 millimeter. That would induce a lot amount of scatter and halos out there. And how decentration evaluation and applying laser. This part is evaluation. This part is all about correction. So how do you do the workup? When you do the workup, the most important thing is ask if there is a symptom. If you have a decentration and you have a symptom, you do see glare, halos, night vision, or you don't have it. There are at least 30 to 40% of them, the brain neuroadapts. You don't need to do anything with them because they're happy with glasses and contact lenses. If yes, if you put a contact lenses, it's a rigid lenses because it reduces the aberration. And most of the time, the cornea is the culprit. You know that why the patient is unhappy. The problem is in the cornea. When there's no improvement, and then for them, you consider laser. When there is no improvement, look out. If the cornea is not your problem, look out for your lenses, your higher order internal aberrations, and think about a lens-based ablation if it's a lens is a culprit. And the DLI and other things which I'm going to discuss is going to be part of it. Still, this is normal. The lenses are normal, internal aberration are normal. Then look at non-strabismic binocular single vision SUSUs, which needs to be treated accordingly. And in lens-based procedures, if your cornea is irregular, you can actually treat the cornea first and then do the cataract surgery. This is the protocol, what we follow for decentration or glare or halos at night. This is I already explained about the role of contact lenses. Lens status is very important, and your DLI or PNS reading on the pentacam is very useful. And you can even use if you don't have the eye trace, you can use the internal aberration from the OPD3 scanners. The ocular motility is one of the most important factors in today's world, especially when you are under lockdown, and 99% of them are doing some kind of work, excessive work with the visual monitors. The most important thing is your ocular motility. And we have again come out with some guidelines on this. It's called the Rome guidelines, the refractive surgery ocular motility impact nexus. What it means is it looks at how the ocular motility have an impact on your being unhappy or happy post-surgery. Non-strabismic binocular single vision is one of the most common masquerade, which you need to always look for. So when a patient comes to you, before you move to anything else, make sure that you pick up somebody in your team who can do a very good orthoptics evaluation. Look for accommodative issues, look for vergence issues. It is very important that once you rule out these two issues, look at office-based or home-based exercises. These are flippers, these are office-based exercises, symbol cards, block strings. This helps to bring in a lot more strength to their ocular motility. So when you look at the glare, which is again one of the most important factors, you look at, again, I mentioned in the beginning, it's more like a recap here. Look at the epithelial mapping out here, assess the myopial strength, and see if it's a true regression. This is more for regression when the patient is come to you saying that he's got a power back, and this again always a cause of concern. If it's true, do a retreatment. But if it's normal, and then you see a lot of changes in the densitometry can happen anytime after the age of 40, then you probably need to take care of a cataract surgery out here. But what is most important is pseudo-regression. This is a patient who may have even up to a -3 or 4 diopters of regression. 99% of my practice, this is the problem here, is most of the time, the pseudo-regression here is always looked at it as a true regression, and sometimes it's just treated with laser correction. But after a few months, you go back again to -3 because the regression is not related to your change in your axial length or change in your curvature. It's because of poor accommodation of convergence, which needs to be taken care of. And finally, what we important is the type of personality you deal with, because many times a very stressed, or we call it in simple words, a type A personality usually end up with these kind of pseudo regressions because they are always under kind of a spasms. And this is very important for us to have a look at it later. So I did mention about the personality. There are different personality scores. And one of the personality score which we use in our practice is the IC personality scores. It's very important here to understand that at least if I look at the percentages, at least 30 to 35% of them fall into optics. Very little in today's refractive surgery, less than 5% are this. I would put around 80% of my patients today who come with glare, regression, or unhappiness is this. And this are always together, which I feel out of 80%, probably around 75% of that 80% is always the personality, which is kind of a little different. All of the above is always, I would say, around 5% of them would fit into all these three categories. But in today's post-COVID era, this is the most important thing. So whenever a patient comes to you with regression, glare, halos, sudden onset of unexpected symptoms which you can't explain, remember this, concentrate on your ocular motility and you'll always find an answer. Thank you.